Dr. Jen, thanks so much for being with me and navigating the tech challenges we that we had getting going.
Got it.
Tell me, if you don't mind, a little bit about why you're so passionate about this topic of sexual health and intimacy and menopause and what's driven you
Well,
to this work.
that's an interesting question because I trained as a urologist, okay, and female urology, and it was a consequence of the time that I was in back then, in the late 1990s. Viagra was just getting approved for men, and Bob Dole was coming out on national television with his ED. And there was a lot of discussions and conversations and hype around this little blue pill that helps men perform better.
Hmm.
And I saw and was experiencing as a woman, being a woman myself, and the only woman in the Department of Urology at that time in my training. There were very few women were going into urology at that time. Now there's a lot more. But I noticed the disparity in how the medical community addressed female sexual health issues and concerns and to male health. And it was a huge disparity and discrepancy.
Yeah.
And it was at that time that I saw the void and that was in the thick of it because women were calling the clinic, well, what about me or what about this? And now you've given him these erections and I'm dry and in pain and I want nothing to do with it. And
Yeah.
calling them the Viagra widows. And I felt like we were doing more harm than good. And that's really what set the ball into motion in my own mind that there is a need here, there is a gap in our understanding. This is considered a taboo subject. There's a lot of shame associated with it still, and that's kind of what spurred me into doing the research and forging and pioneering the field now of sexual health in women, that there are real medical physical reasons, there's emotional reasons, relationship reasons. I thought,
Right.
I'm not denying that, but there are also medical physical reasons that women experience issues that can be treated medically and that they should have the opportunity to do that if so wanted. Now fast forward, here we go. That was late 1990s, and I'm in my mid early 30s. By the time I'm in my mid to late 30s, I happened to personally be going, I delivered my second baby and I went into perimenopause very
Mm.
quickly. And I was in the middle of a fellowship. And so this was in 2002, 2003. We're
Yeah.
now 2026. So how 20 years later, and we're just now having these conversations. You can imagine there were no conversations going on back then.
Yeah.
And then treating a woman that was perimenopausal, not menopausal yet, which was me, was considered absolutely like blasphemy. It was like
Yeah.
Charlotte, they were crazy about that. But I knew based on the research that I was already doing the benefits of hormone replacement therapy in perimenopause and menopause women. I knew already how to dose testosterone in women because I'd already been doing it with the sexual health side of things. So it was a very natural evolution for me to kind of parlay the aging woman into my paradigm, and the aging
Yeah.
woman was me.
Yeah.
And so I became my first patient, and then the rest was history. And I was working in a vacuum for many years, and it was very frustrating and um, difficult, dealing with the naysayers and the confusion and the concerns related to breast cancer with
Right.
misinformation on the one hand. But on the other hand, I was able to build my practice based on the neglect of the medical community and the fact
Yeah.
that 90% of our gynecologists, who are the gatekeepers to women's health, weren't trained properly and didn't have the tools, the education, or the confidence and knowledge to treat women with hormone replacement therapy. And
Right.
now suddenly that's changing. And what spurred the change, there was a couple of things. I think it's really the technology of modern times, with social media and women able to talk to other women
Yeah.
and information. And then, wait, you did this, wait, you saw a lady there, wait, your doctor said that. And it was this movement that's happening is being driven by women, the consumer, not the medical community, not the FDA, not our government, not the healthcare community for sure,
Right.
but
Right.
it's being driven by women. And what's still frustrating to me, which is why I want to do podcasts like this and many others, is that there's a movement happening without a voice and without a leader, and we're just creating, in my opinion, more confusion, more chaos, because there's no consensus. What the
Mhm.
doctor in Florida versus the doctor the same in New York, we're saying two different things. You could get two different opinions on the same problem, and
Right.
that's not good.
Yeah.
So there's still a lot of work that needs to be done, but it is getting better in
Right.
terms of our awareness.
So you mentioned some of the things women experience with menopause, dryness and pain and things like that. I
Hmm.
mean, I think for a long time it was just assumed, well, we hit menopause and it's over. At least, our
Yeah.
sex life is over. Who knows what else is over? But you kind of reframe that, right? You think about this differently as an opportunity.
Well, it's an opportunity to age gracefully. Like, look, the way that I look at it is, there in all this longevity and anti-aging medicine, we're talking about living longer and extending. I don't know if we can actually extend the number of years from whatever our clock is, but what I do know that we can do is, for whatever that last 10 to 20 years are, that we have the technology and the tools and the information today to dramatically improve the last decade or two of our lives from what we were before, from the time of even my parents, who were um, on the cusp end of baby boomers, that were living happier, healthier, more vital, active lives, including as it pertains to sexual health and intimacy.
Hmm.
So that's really, my goal in all of this is to help women live happier, healthier, sexually fulfilled lives throughout their life cycle. And the way that it's been to date is what you refer to is, we see the gynecologists, there are gatekeepers to women's health through our reproductive baby making years. And then as soon as that's done, then it's like, okay, we're done with you. And then when these issues come up, women, and this was the most frustrating, that what they're told is, oh, this just happens when you get old, or this is
Right.
menopause,
Right.
or you're moody, let me put you on Prozac, you can't sleep, here's some Ambien, you're getting fat, here's some this, that you're treating, the symptoms, not the cause, which is hormone imbalance. And for many, many, many women, it's not just a small handful, estrogen imbalance and declines in estrogen levels can dramatically affect quality of life, your emotional well-being, your mental health and well-being, and your cognitive function, your ability to function in the world, to continue to be productive and work, to be on a level playing field with men in the workplace. It's impossible to do that during menopause without hormone replacement therapy. And the fact that we've been having to do that for
Yeah.
centuries, decades, if not centuries, is really what we should be, the question we should be asking is, why is that? And I have my my conspiracy theories. Like, just imagine if women, throughout this whole time, once women are on testosterone, which is what's happening, we're getting treated. They're getting it now. There was a huge scare about it. Now that's even become more mainstream, because we've learned that testosterone is protective against breast cancer in the breast. So
Right.
now, like, oh yay, not only is it going to make us more libido, more energy, more lean muscle mass, but now we're not going to get breast cancer too. So there's more interest in that. So now women are going to be optimized on hormones. We're on testosterone. So now we're better than men, because
Watch
we're better
out.
than men anyway. We're better multitaskers, we're better leaders, we're better at a lot of things, and keeping us sound and vital and able to remain in the workplace into our 60s, 70s, and on, like men are leading companies.
Hmm.
That there's going to be a shift, I think,
Yeah.
and I hope.
Yeah. I mean, it's so powerful hearing how these other areas that the hormones affect and how impactful this is, like across our entire life.
Hmm.
And as a sex therapist, I'm always particularly interested in sexual health and functioning. I mean, you really
Hmm.
look at that as like a clinically important aspect, right? Not just because I talk to so many older women that just sort of think, well, it's over now. It dies with the hormones. No big deal. They go to the doctor.
No.
They don't get any
We're
support.
gaslit to
Yeah.
believe that. But sexual health is a critical component of general health and wellness. And when is from the medical standpoint. So when the issues arise related to blood flow or sensation or engorgement and arousal, that's signs of vascular issues
Yeah.
or neurological issues or due to a medication or a surgery or some other thing. So yeah, so intimacy and sexual health is a critical component of general health and wellness. It's also critical to who we are as human beings, to connect with other people, to share intimacy with other people. It's hardwired in our DNA. And with aging and menopause, it's very easy for women and now to kind of pull back from the physical part, and the nature of the relationship can change, can become more of a loving kind of a different kind of intimacy, and that's fine if both couples are on the same page.
Right. Right.
But that's really not the way it is, because men are getting pushed with testosterone, and when they go to get their annual exams, even that, not even if they may not even be having erection issues, they go to their primary care doctor to get their annual exam, and those doctors are now giving men testosterone and Viagra. So it's there's a libido mismatch. That's what I'm
Yeah.
seeing a lot. And either the men are pushing their wives into care, or the women are so frustrated and feeling so guilty or frustrated with being the pressure that they bring themselves in. And it's not really important to them, but it's important to their husband. And then there's many that I remember what it was like, and I miss that, and I want it
Right.
back. That's
Right.
really more what I see than the other. But like probably about 5 to 10 years ago, it was more husbands pushing their wives or wives reluctantly creeping in.
Right.
Now that we're woke, that
Now that we're talking to each other. Yeah.
women are being more proactive, and even younger women. I even have women pre-perimenopausal that are worried and thinking like, I don't want this to happen to me, or what can I do now, to make it easier, for me to transition. And now also on the rise is, I don't know, you probably hear about it in sexual health conversations too, is this PCOS
Hmm.
is on the rise. When like younger girls are getting their periods earlier, are having problems with their cycling hormones. There's like this shift in hormone issues happening earlier and to younger girls. So I'm curious as to how that's going to play out
Yeah. Yeah.
in the future.
So let's talk a little bit about HRT. First of all, you sort of mentioned a little bit, you alluded to some of the myths or misconceptions about it. Is there anything you want to sort of lay out specifically that people may not understand about the safety of this, the naturalness of
Well,
this, the
I'll
benefits of this?
say, and hopefully this will sound like a broken record, but I'm going to say it again. Estrogen does not cause breast cancer. That's probably the biggest piece of misinformation that persisted over time,
Yeah.
despite an effort to recant. So when there was, I'm referring to the WHI study that was run and presented by the American College of Obstetricians and Gynecologists, a multi-center study where they came out with a statement that estrogen causes breast cancer. And very shortly after that, it was about 3 months after that, more data came out, and they said, oh, okay, darn it, it doesn't cause
Oops.
breast cancer. Well, we're going to take that back.
Wow.
However, you can't really take that back. You can't
Yeah, once
unsee it.
yeah.
And when they took it back, they didn't provide algorithms, protocols, ways and tools for their providers. Well, it doesn't cause breast cancer, but it does this, and this is how we're going to do it. This is how we're going to treat the menopause one. They just left over a decade worth of providers unarmed, untrained, and uninformed about hormone replacement therapy, the benefits of it, how to use it, and the safety of it. So they
Yeah.
acknowledged it doesn't cause breast cancer, but we're just going to say it's bad. And they thought, well, it causes Alzheimer's disease, it causes cardiovascular, everything, every issue that they assigned to estrogen as negative turned out to not be the case and not be true.
Yeah.
So I really want to emphasize that. And then in terms of the concerns and where the risks were, the hormones that they were looking at were synthetic hormones, not
Mm.
bioidentical hormones. And it was the combination of synthetic estrogen plus synthetic progesterone given orally in the form of Prempro, which we don't do anymore. We don't give estrogen orally, at least we shouldn't be, because orally, nothing to do with breast cancer, but orally is what causes all the cardiovascular risks, the thromboembolic events. So
Yeah, yeah.
we don't give oral estrogen, but that was what they were looking at: oral synthetic combination of estrogen plus progesterone. What we're using now, what the recommendations are, is not synthetic combo oral, but bioidentical, meaning the same form of 17 beta estradiol as your ovaries make. We have that available. There are FDA approved versions of bioidentical estradiol that are commercially available. There are commercially available bioidentical natural progesterone, not synthetic progesterone, that's available. What we don't have available, or we have it available, but what's not FDA approved yet for use in women, is testosterone.
Right.
So what that means is that we have to compound testosterone from compounding pharmacies, and we can compound testosterone in any different form, in patches, creams, pellets, lozenges, drops, troches. There's a million and one different ways. But the challenge is that every woman responds differently, every woman absorbs differently, every woman's levels, your level that you need to be at to feel your best, to feel optimized and have side, is entirely different than what mine is.
Mm.
And gauging that, so this is where the experience comes into play, the the knowledge comes into play, is reading the patient. Is this a fast responder? Is this a slow responder? Is this somebody that I can go up on the dose or down on the dose? Is this somebody that can take the combination form? So and that's based on your DNA. And although all of us are basically we can all take the same medications, but if we're talking about a future of personalized medicine, individually tailoring to meet, which is the goal, or our goal at least,
Right.
for the future. We're still kind of in the dark ages as that pertains to menopause. But that in a nutshell is why I created myself. I created a test called the Menopause Biotype, which is a genetic test. And I created it for this purpose, to help patients and their doctors, because this was in the time when doctors weren't trained. They were
Yeah.
scared to give hormones. Patients didn't know, do I need them? Do I not need them? So the menopause biotype is a genetic test, like it's a swab, a 23, like the 23andMe, and which gives data about how you metabolize hormones, what combination of hormones work best for you, and what symptoms. I didn't realize this until I created this test and did all the research, that the symptoms that you get, or I get, or she gets, that we are predictable based on our DNA and the
Wow.
severity of them. So if you knew at 38 that you had a propensity, a risk for becoming morbidly obese during menopause, which many women do, then you could take preventative measures and take steps to, to avoid that or to prevent that. So mitigation of risk and disease was one thing, and also, for knowledge is power, and that
Yeah.
when we know what to expect, then we can, take the steps to live the best lives that we can.
So are you saying that the DNA, the genetic impacts and correlations are fully understood and you can look at this DNA sample and you know everything about how what somebody might experience with
But
menopause and hormone
believe it or
replacement? Or are you
not,
still discovering more about this?
we're we are still, each moment there's more genes, so we can look at now, like how fast versus slow metabolizers. We can determine whether you, so that once we give hormone replacement therapy, there's a subset of women, for the mental health issues, hormones help considerably, and then many women, that's all they need. But there is a subset, and it's not a small group, that doesn't, that yes, hormone replacement therapy helped their mood issues, their anxiety and depression and whatever is better, but they still struggle. They're still on, even on mood stabilizers, even with therapy. We found genes that are common to those individuals
Yeah.
that have to do with stress responses and cortisol and the MUTHR. So that subgroup of women had, so now we can predict. So then if we can predict that you're going to get, better with hormone replacement therapy, but you still might have these issues. And if you still might have these issues, then these are the other things we can do. And what I'm doing, this is new. I just identified that other subgroup that's still struggling with mental health issues. And what I'm doing in them, this is brand new, is you're probably going to think it's really crazy, but it actually, there is data, is in that subgroup of women, and they have commonalities in addition to their DNA. I tease this out. So these are the commonalities. One, they have a history, all of them, a history of early childhood or early adulthood trauma. So
Yeah.
that. Second, they have the way that they're wired. They have difficulty regulating their emotions anyway. So up and down and highly sensitive. And C, the third thing is that these patterns, their triggers, whatever it is, whether they're thoughts or feelings or some other situation, activates, that they struggle with these loops that are running, that they absolutely cannot break, despite cognitive behavioral therapy, hypnosis, and other things. So what one of the things that I learned about was ketamine therapy.
Mm.
Do you know anything about ketamine
I
therapy?
only
So
had limited, very limited amount. Yeah.
well, from the standpoint of what they learned, and there's studies going on at Harvard and Stanford right now in perimenopause and menopausal women on and off hormone replacement therapy. And what they found is, and this is what the neuroscientists initially came out with, they were the ones that sort of opened the conversation. Your brain's shrinking, with menopause, and that estrogen is 100% necessary in terms of calming down the excitability in all women, and particularly these women. But what happens with ketamine is, the other thing that they have in common is, compared to normals or controls, let's say such as you versus me, if I, whatever it is decrease in, there are two things, brain derived BDNF and glutamate, and their neuroplasticity is stunted
Mm.
compared to others. So that, if you're kind of unable to expand out of these loops, it makes it really
Right.
difficult. And
Right.
what ketamine does is it allows that enhancement of neuroplasticity, and then you can change the narratives. And I found, again, I'm early on this little discovery of mine, but really really excited about it. That's one of the things, I don't know, when we were starting, she came in and she said,
Yeah.
asking for a phone number. So I've partnered with an anesthesiologist here in Los Angeles who specializes in ketamine therapy. He found, actually, it was interesting because he found on his own issue, like in treating women, some women would respond really well and others responded but not the same, and he
Well,
didn't
they need both,
understand.
right? They need the HRT and the
Yes,
ketamine. So
they
interesting.
both.
Interesting.
Not all women, not all, but
Right,
in what
right.
in those that still struggle, they do. So I think we're going to be seeing more, but that's just one other thing that that genetic test does, and and lots of other things pertaining to stress, how stress impacts and your ability to manage stress, and how that impacts your hormones, and it's just getting closer to precision-based medicine, where we're treating the cause, not just throwing,
Yeah,
medications at symptoms,
right.
which will
So if
hopefully
somebody
help.
works with you, you start out with that genetic test, and then how do you, what's the general course of treatment in your approach?
So the genetic test, ideally, yes, that they would start out with the genetic with that genetic test and labs. So we would have them get their labs drawn before they even see me, because I need that. I need the labs to have a frame of reference where you are right now. And the genetic test gives me information to pay. Okay, this is going to be a slow metabolizer versus fast metabolizer. This is going to be somebody who is that struggles with mental health or emotional health issues that I have to be aware of, and this is there are other issues about the symptoms that they may develop, in terms of hot flashes. Like we can measure the severity, we can assess severity of symptoms of all of them, of hot flashes, of the cognitive decline with aging, the risk of diseases associated with hormone balance, with Alzheimer's, colon cancer, osteoporosis, all of that. And so when women are armed with that information, then they can take the necessary steps here. So there there we have information to address the woman's current condition and current symptoms, what we're predicting could be things that she could develop in the future, and also prevention of diseases associated with
Right.
hormone
And it sounds
imbalance.
like likely response to HRT too, right? It might inform where you're starting in terms of prescription levels and things.
In terms of dosages, yeah,
Yeah. Yeah.
and in particular with regard to pellets, I'm a fan of the pellets, is the spacing of them, like how normally they last about 3 to 3.5 months, but some women can extend 4 to 6 months, and I can tell that. And so why that's good, because a less expensive, that pellets aren't covered by insurance at this time, so if you're not having to come every 3 months, but you're coming every 4 to 6 months, that's less times, less issues. And then also, just for ease and facility, not having to put on creams, not having to take pills, not having. So there's a number of reasons why I prefer the pellets, especially as it pertains to testosterone. But the metabolism, the way that people metabolize hormones is different. And then some women don't tolerate the creams or the patches. It's impossible to get them to a therapeutic level, or if you get them to the therapeutic level, they have tons of side effects, associated with it. So, it's still a little bit of the wild, wild west, at least as far
Yeah.
as I'm concerned, because I try to get like I've been doing it so long that I don't follow, like I have a general sort of frame for
Right.
different people, but the way that they're learning now, these new doctors on Substack and taking weekend courses, this is what your level needs
This
to
is
be
like the
here.
protocol. Yeah.
This is,
Yeah.
but you can't do it that way,
Yeah.
because you can't say that the estrogen level great less than 40, that like everybody is different. My estrogen level, I know, is in like 222, is super high compared to most other women. Most other women can be 40, 60, 80, 108. Mine 200, between 220 and 280, for me not to have hot flashes and for me not to be crazy.
Wow.
And
Okay.
and but with these other GYNs and other practitioners that are practicing medicine and learning, that they see an estrogen of 280, they'll be like, oh my God, that's too high. And
Right. Right. So
so
you're taking the labs combined with symptom report and what people are telling you
with
about their experience, lived
and the
experience, right?
genetic testing,
Yeah.
yeah.
Yeah. And are you working with people in perimenopause too? I mean, at
Yes,
what
yes.
age do you think people, or at what first symptom or experience should people even think
The
about?
first symptoms in perimenopause usually are um weight gain, low libido. So they'll notice that they're less low libido, and moody.
Okay.
Those are probably the three. And then the hot flashes and night sweats don't start. Some perimenopausal women might feel sweaty at night, but by the time you're having hot flashes and night sweats, that's more towards menopause.
Right.
And then what the other thing that the medical community was doing is taking women off hormone replacement therapy after they'd gone through menopause, which
As
is
if
not
it's
a good
over. Yeah.
idea because everything gets worse.
Yeah.
Granted, your hot flushes and night sweats eventually stop, but everything else stays or gets worse.
Right.
The vaginal dryness, the low libido, the fatigue, the loss of lean muscle mass, the difficulty falling asleep and staying asleep, the memory, focus, concentration, creativity, intelligence, lean muscle mass, everything, continues to
Yeah.
deteriorate with, if you're not, everything starts and stops with hormone balance. Every
Right.
cell in our body, every blood vessel, every nerve is dependent on hormones. And so
Yeah.
it, the fact that we are just now realizing how important it um, is is alarming. But
Yeah. But I suppose better late than never,
yeah,
right? But yeah. And is it ever too late for somebody to look into this and start treatment?
I don't think it's ever too late. The concerns that we have in an older woman, let's say, a postmenopausal woman who hasn't been on hormones before. Now, the if women have cardiovascular history, like high cholesterol, high blood pressure, potential for plaque buildup in their body, even though we're not giving oral estrogen, even the transdermal estrogen can potentially have risk if you already have plaque built up. So a fresh menopausal woman, 40s to 50s, we can just put them on it. But somebody that's older that hasn't been on it with these histories, at least in my circuit, my for my peace of mind, I have those women cleared by their cardiologist. I usually will get, if they have high cholesterol or they're on a statin or cardiovascular risk factors, I'll have them get a calcium scan to make sure that they don't have plaque. And if they do have plaque, the cardiologist will clear them. And so I have women late 60s, mid 70s, early 70s, mid 70s, like mid to late 70s. I've had patients come in and ask for hormone
Yeah.
replacement therapy. Frequently at that age and stage, once they're not having hot flashes anymore, some of them will get by with just testosterone for energy, for lean muscle mass, because you start to get like squishy fat, like where you're working out, eating healthy, and not getting results. So some of the older women will do well with just testosterone. Other ones still require estrogen for mood, for sleep, and for vaginal and urinary tract health.
Right. Right. All right. So how do people reach out to you? What do you want to what do you want to say about who you work with and how where do
I
people would
have my
start?
website. My website is bermansexualhealth.com. You can find out about all the stuff that I do in terms of hormone replacement therapy and sexual health. And my Instagram is at Jen Berman MD. I There's content up there about hormone replacement therapy, and then also about sexual health, things that we can do to optimize sexual health. Peptides, I've gotten into peptides in the last couple of years, where peptides had been mostly in, again, the longevity, anti-aging, naturopath kind of circles, where the medical community scoffed and said that's not, we don't think that's science. That's also changing. And while they're not regulated by the FDA, there is a increasing amount of data showing the benefits. And a lot of these peptides now, I have learned, are in clinical trials, um, trizepatide. The GLP-1s were
Mm,
peptides that they turned into drugs. So my prediction is a lot of these peptides, especially the good ones, there's one to pay, like, invest in this if you see it. It's called BPC 157. It's a peptide. And there is a pharmaceutical, it's in clinical trials right now. I know Dr. Phil invested hugely in the company. I can't remember the name of it that's building it, but that peptide is going to probably take out Tylenol as over
wow.
the counter Tylenol and Advil, because it's safe, doesn't have impact on your liver or kidneys. It's really a potent anti-inflammatory, analgesic, safe and effective therapy. And so that's just one. There are many other ones that are in development and are available. And peptides are basically natural proteins that we all make.
Right.
And as we age, the quantity of them declines and the quality of them
Yeah.
declines. So I see a future with where peptides are going to be offered more liberally, and we're going to start pulling away from a lot of these heavy duty
Yeah.
um, drugs that we're slamming on people that
And
have
people can
side
learn,
effects.
they can learn more if they follow you on Instagram, right? This is something you'll keep talking about
Exactly.
and keeping people up to date. Perfect.
Yes.
Well, thank you so much for being with me.
Well, thank you for having me. I've enjoyed it very much. And if you need anything else and any other topics, let me know.
I will.